Hello everyone, my name is Kasten and I'm a fourth-year physiotherapy student. For my graduation project, I've conducted a literature review to see if the unicondylar knee arthroplasty is more effective than the total knee arthroplasty in terms of patient-reported outcome scores. These patient-reported outcome scores in this case being pain, function, self-reported health state, and return to sports. This video is a quick pitch about my This literature study was written in the form of a Cochrane review, where the main focus was on systematic reviews, but some primary articles were also included. All of the literature was from the last 10 years to make sure that the latest results were used. Below, the problems that were studied and the most common tools used are illustrated. Pain was measured using the numerical pain rating scale and the visual analog scale. Knee function was evaluated using a lot of different tools, but the most common ones were the Knee Society score, the WOMAC, the Bristol knee score, and the Oxford knee score. Return to sports was measured by the number of patients returned to the same level of sport activities. And finally, the self-reported health state was recorded using the EQ-5D VAS. My review included 2 search rounds to identify as many useful articles as possible. In the first search round, 1 general search string was used, which included both interventions and synonyms. The search on PubMed and CNOW were filtered for systematic reviews only. After the final screening through the exclusion and inclusion criteria, 6 articles were included. For the second round of the search, a different search string was used. This one included both the interventions and the outcome measures, in this case, PROMs. The search was not filtered for systematic reviews and included all types of scientific articles. After identifying articles, a search function was used to determine if they'd been studied in the systematic reviews that I included in the first round. This was done to prevent duplicate studies that may skew the results. Again, PubMed and CMA were used. At the end, 3 final articles were included. This slide shows my data extraction table. I put the most important factors as column headings. In this case, the study design, follow-up time, outcome measures, and the conclusion of the study. In the next slide, I will demonstrate my interpretation of the results for each PROM. Below are the results of 7 studies in terms of functional outcome in patients. There were a lot of different tools used to assess the function of the knee, but the Knee Society score, the Oxford knee score, and the WOMAC were the most commonly used ones. 100% of the studies showed a better outcome for functional PROMs after UKA compared to TKA. 29% of these studies also took a closer look at how the time after operation seemed to affect the function scores. These studies indicate that the UKA seems to perform better in short-term recovery, but with time, the TKA seems to perform better, since at 2 years the scores are comparable, but at 5 years the TKA has better scores. This slide contains the results of 3 studies for the comparative pain scores for each arthroplasty. 67% of the studies found no statistical significant difference between pain after UKA and TKA. The remaining 33% showed a statistical significant better outcome for pain after UKA compared to TKA. These results indicate that the UKA pain scores seem to be either equal to or slightly better than the TKA. For this slide, 3 studies were used to come up with results for the patient's return to sports after UKA versus TKA. One of these 3 studies was not able to analyze the return to sports due to insufficient studies available, which means that it's eliminated from the results. 100% of the other studies showed a statistically significant better outcome for rate of return to sports after UKA compared to TKA. Below are the results of 3 studies about self-reported health states according to the EQ-5D VAS. All of these studies found statistically significantly better scores for the self-reported health states after UKA compared to TKA. These studies also indicate this better quality of life after UKA compared to TKA in both the short term, 6 months, and the long term, 5 year. In conclusion, my research has shown that the UKA is more effective in terms of nearly all PROMs than the TKA. The results for function, return to sports, and self-reported health states are all very positive for the UKA. The only problem where this is not quite as clear is pain. Pain scores for the UKA seems to be either equal to or slightly better than the TKA, but the largest amount of results are still leaning towards the equal amount of pain after UKA compared to TKA. I believe that all of this information should be given in the shared decision-making process with the patient, but there should also be other information from other outcomes, such as survivability of the prosthesis and complications after surgery. But how can this research be used in practice? Both UKA and TKA are viable options for the treatment of medial osteoarthritis. But according to my research, there are specific patient groups that can significantly benefit from the use of UKA. One of these patient groups is patients with severe comorbidities. According to Pratt-Uribe et al., UKA was found to be safer than TKA in multiple outcomes, including PROMs for patients with severe comorbidities. These comorbidities were measured by an ASA grade of 3 or 4. Also, patients who are very active or who want to have a higher chance of maintaining their current sports level should be recommended for UKA. Both Vitjes et al. And Papali et al. Found that the rate of return to sports is higher with UKA. UKA and TKA performed similarly in low and high impact sports, but UKA performs much better in intermediate impact sports. Also, the time to return to sports is slightly lower for the UKA. Lastly, patients who wish to have higher function scores more quickly should be considered more for UKA, as UKA in terms of function seems to perform better in the short-term recovery, according to Liu et al. And Knifson et al. My recommendations for the future. Further research of later years is still needed, as most studies had a mean follow-up time of only 5 years maximum. Also, a recommendation for the individuals who do the follow-up tests. I recommend using a centralized sets of PROM data collection, such as the ISHAM. This helps improve studies, as these tools have been proven to be effective in this situation, and because it makes it easier to analyze the data. Thank you very much for watching this video. At this point, I'd like to thank everyone involved in my research project.